All right. Good afternoon, everyone. I don't know if John, if you can hear me, if you're there.
Yeah, all good.
Awesome. Cool, guys. So it's 5 o'clock, and we've got quite a lot to go through. So I think we may as well get started. Um, John, just wanted to thank you for making yourself available to be with us this evening. It's really awesome to have you, and I think I don't know if you are experiencing the same thing, but I'm working at Impulweni Hospital, and we're really seeing a massive amount of collateral damage from COVID in terms of patients interrupting their ARVs and presenting with very low CD4 counts and opportunistic infections as a result of treatment interruption. And things are a little bit more confusing now that we're in the dolutegravir era of antiretrovirals. So I wanted to just get some expert input from John, and hopefully it can be a really helpful session. John, where are you currently working at the moment?
Just hang on a sec.
Sure.
So I was having a cup of tea delivered to me at that moment.
No worries.
um, so I'm in Livingston and I do ward rounds at Doringenza. So that's in Quebec now. So I'm part of the infectious diseases service there. And just in response to that, well, first of all, thanks for inviting me to chat. This is one of those issues that is quite difficult, and there's lots of new information coming out, but guidelines always take a long time to change from information to sort of active rollouts of these things. And unfortunately, the dolutegravir rollout has also coincided with COVID, and with that, the collapse of the primary healthcare services, patient fear about not being able to access treatment, fear about COVID and coming into to actually receive treatment. So the viral load monitoring has gone to pot, and there's a lot of issues around how COVID has affected this. But to be honest, we see a lot of this before COVID. Unfortunately, compliance and adherence to therapy is always the ultimate challenge in HIV treatment. So being an HIV clinician would be very easy if people took their treatment. You would have no work to do eventually.
Yeah.
But unfortunately, adherence is always the big issue. And you combine it now with COVID and new treatments, it does become a little bit more complicated to deal with.
Yeah.
So,
Yeah.
yeah.
Cool. Awesome. So I've put together a couple of cases for us to talk through, which basically try and just replicate the issues that we're encountering in the clinical service at the moment. I've put together, I've incorporated some of the polls from the Google form that I shared on the WhatsApp group. So just so John can kind of see kind of where people are where people are at in terms of their current management and their approach to management. So without any further delay, I'm going to jump into the first case, and John, take us away. Here we go.
Okay, so I suppose I'll read through the case. 29-year-old gentleman who presents to your hospital, wherever that is, with features suggestive of disseminated tuberculosis and a positive urine lamb. We are assuming in this case that he's had no prior TB. And on further questioning, he tells you that he was diagnosed with HIV in 2018 and started on a combination of tenofovir, emtricitabine, and efavirenz. He stopped taking this treatment when his clinic closed due to the COVID outbreak. So we would say that's about 2 years into therapy. And so that was about a year ago. So so we're looking at about 2 years on therapy. What we don't have is the history of when he was on therapy, what his viral loads were and what his adherence pattern was like. But his current bloods, as we can see them there, is a CD4 count of 3. He's CLAT negative, a viral load of log 5 with a hemoglobin of 6.8 and a creatinine of 48, and his hepatitis B surface antigen negative. So perhaps we can go to the first question and then we can reflect back on some of these issues as we go. So when would you initiate ARTs in this case? Well, you know the patient has a CD4 count of less than 50, and we know there are numerous studies looking at whether there's a delay in effective therapy beyond the 2 weeks in patients with CD4 counts, specifically less than 50, there's a much higher mortality. So within the first, I wouldn't say after 2 weeks, as soon as the patient, the general teaching here is as soon as the patient is clinically stable on their TB treatment, you would initiate effective ART. And I emphasize effective ART because there are a number of questions in this case about what we should do. And that's up for discussion. Okay, can we just go to the next slide? Okay, would you give prednisone to prevent iris when reinitiating ARV? So I thought, let me just deal with this question first, and then we'll get to the ARV choice later. And we've said yes in 63.2% of cases. So perhaps we can, did anyone who respond to yes, perhaps we can get maybe some comments from the gallery as to on what is that decision based, and then we can maybe talk a little bit about that.
Cool. Yeah, awesome. Is anyone on the chat who responded to that question affirmatively? I don't know if you're happy to just pop yourself off mute and answer, or if you can also just put a message in the chat if you'd prefer. Okay. Well, maybe while chats are coming through, I mean, obviously I put the slideshow together, so I'm sort of directing conversation in a certain direction. But yeah, I've heard about the PredArt study, and so I would treat with prednisone upon initiating ARVs based on the PredArt study. I'm not sure if anyone else has any comments. No.
So was that someone else coming in there? Or? Okay, so I think where I would, the PredArt study is a very important study. I think when we're looking at prednisone, when it comes to TB, there's a whole range of different issues associated with it and some key things that we need to understand. Okay, so obviously in those with active tuberculosis, there is the use of prednisone. Specifically, there have been multiple clinical studies that have shown evidence in HIV negative patients for TB pericarditis. The MP trial was one of those issues with TB pericarditis where there was a concern about an excess in malignancies. A lot of those patients weren't on ARVs, and that was specifically driven by Kaposi sarcoma. Obviously, we use it in TB meningitis. A lot of the evidence there, again, is extrapolated from HIV negative patients. And then we use it in, it has been shown in TB iris in one of the clinical studies that Graham Reinke's did initially. So this PredArt study was really positioned to say, look, can we prevent TB iris in high-risk groups? And the specific trial, again, looked at those with a CD4 under 100 who within the first, I think it was 30 days of initiating their TB treatment started prednisone. They were all on ARVs at about the same time of prednisone and looked at what the rates of iris were to see whether there would be an improvement in reduction of iris, reduction of secondary outcomes associated with iris. And what was really interesting in the study, I don't know if I can share the screen. I've actually got the paper if you wanted to have a look at it.
Yeah, I would just have to change the settings here. Okay, cool. Do you want to see if you can share your screen, John?
Okay. We have to stop sharing first. Just hang on a sec.
Sorry, John. I think there was one setting that I hadn't changed, and I've now changed it, so you'll have better success now. There we
Okay,
go.
so you
Yeah.
can see so this is the PredArt study, and as you can see, so they used 40 milligrams of prednisone for 14 days, followed by 20 milligrams for 14 days or placebo. And the primary endpoint was iris within 12 weeks. And you see the median age was 36. CD4 counts, you can see median CD4 count was 49. And what was really interesting is if you go to some of the graphs, you can see the incidence of iris in placebo was almost 50%. So you can see iris is incredibly common in this. Just keep in mind that this is a high-risk group. The incidence was higher than they expected. And even with prednisone at that dose, was sitting at 32.5%, but there was an improvement in terms of iris, in reduction of iris by an absolute number of about 14%, about 14.2% was about a 30% reduction. And then there were some secondary outcomes that were improved. So in terms of the iris duration, and in fact less adverse events, which has been shown in a number of other studies. A lot of it was not significant, but there was a trend towards an array of benefits of prednisone over placebo in these. So I think that's one of the big issues here, is that prednisone does have important effects in these patients, but it does come at a caveat. You need to realize what the contraindications are, and if you look at the study, there's certain contraindications to the use of prednisone. So does anyone know some of the contraindications to the use of prednisone when trying to treat a patient with HIV specifically? No? Okay. No one's
Sorry,
taking it back today.
John.
Okay. So just remember that prednisone is an immunosuppressant, and HIV patients often already profoundly immunosuppressed. And there's obviously the concern around specifically chronic viral infections. So chronic viral infections include all your herpes viruses, which are effectively latent viruses, which can reactivate. So you need to think of common herpes virus associated diseases, Kaposi sarcoma, which is from Kaposi sarcoma herpes virus. If you've got active Kaposis, you certainly don't want to do it. Okay. Remember that you can get a reactivation of herpes simplex as well as varicella zoster. Okay. And then if you have something like active hepatitis B, so chronic hepatitis B, you can certainly reactivate your hepatitis B with this. So certainly you want to make sure patients, if you're going to throw steroids at them, that you need to know that they don't have active hepatitis, Kaposi sarcoma, or any of the other chronic herpes virus family diseases. And you need to make sure that it's given in combination with the ARVs. Obviously, if you're giving prednisone without ARVs, it tends to be a problem. We do that in TB meningitis, but there the risk-benefit issues are more in favor of giving it, even though we're not giving ARVs, because there the risk of iris is a bit more concerning. So in this case, it would be reasonable to give prednisone when reinitiating the ARVs to reduce the incidence of iris, which has an incidence here, you're sitting at between 30 and 40%. So I think most of you got that right. But as long as you're aware of the caveats pertaining to when to be cautious about the use of prednisone in these particular patients. All right, so let's go to the next question.
Cool.
Okay, would you start as old regimen or starting on a new regimen? So yes, 88.9% said restart the old regimen. Keep in mind this is tenofovir, intracitibine, and efavirenz. I was quite surprised at this, and I'd be intrigued to know what the thinking was in terms of this. I presume, I can talk through what I think the thinking was, but if anyone wants to perhaps come out and express what that line of thinking was, I'd be really interested.
Yeah, it seems to be a common Oh, is someone about to talk? Sorry. Jess. I see Jess, you've raised your hand. Over to you.
Sorry, I was struggling to figure out how to unmute. My thinking was that you don't, although you don't have proof that the patient had suppressed on his an old regimen, his TE, you also don't have proof that he wasn't suppressed. So my thinking was you want to decrease your pill burden, so that's why you would go with TEE. Well, yeah, so you don't have proof that he wasn't suppressed on his first line, so that's why I would stick with the first line. And then I would restart him on TEE as opposed to TLD because of a decreased pill burden with the fact that he's on TB treatment as well. That was my thinking.
Okay, I mean, it's very valid. So I think the question that you have to ask here is, I stressed quite a lot when I spoke to, when I was going through this earlier about the clinical evidence of when you start ARVs is related to what is an effective regimen. So the question is, what is the risk of restarting an old regimen where there's potentially failure? Now, remember, tenofovir, emtricitabine, and efavirenz is a very low barrier to resistance. So you don't need much in the way of mutations to get efavirenz resistance. It's sort of a single mutation, the same for emtricitabine. So here is a patient who's had at least 2 years on therapy, and we have no viral loads. Now, if we give him the benefit of the doubt and say, look, yes, he may have taken it, there's still significant concerns. So in terms of risk, we know from a number of studies that have looked at patients who present with opportunistic infections, and they look at early versus delayed initiation of ART, whether it's TB or other opportunistic infections. Okay, in those cases, the absolute mortality difference with effective ART comes down from about 1/3 to 1/4 of patients. So you're losing about 10% of patients from a mortality point of view just by a delay in ARVs. So the question is, if you put him on a regimen that may have a crippling effect but is not effective, okay, you've got a patient with a CD4 count that is profoundly suppressed. Yeah, you've got a CD4 count of 3. Do you have the luxury? This is a sort of bit of roulette here. Do you have the luxury of putting them on a regimen that may be failing and potentially increasing his mortality? And how do you make that decision? Okay, so if you've got multiple viral loads that show that he was suppressed over that time, he's got a history of good adherence, and he stopped for whatever reason, you've got the option of saying, yes, his risk of resistance is less. If he's got no viral loads on the system, he's been telling you he's intermittently taking it, you really need to make an individual assessment here. But the safer option, despite the pill burden issue, is to say, look, we don't have much room to move here. We've got a CD4 count of 3. And in this particular sick patient, remember, this patient's got an HP of 6.8, which is an independent predictor of poor outcomes, disseminated TB, and a CD4 count of 3. Can you afford to get it wrong? So that's really the discussion point. The second issue then comes in is, well, what's the best alternative regimen if you're not going to use this regimen? And then we can talk a little bit about that. But I think the take-home message in this one is, do you have the luxury to start him on the old regimen and wait for a couple of months before repeating the viral load to see it's working in him? Okay, and there's no single answer to that question, but I think you must be aware of the absolute dangers in these patients of getting it wrong. Okay, so you're not wrong to say you'd start his old regimen, but I think you'd need more information, and I think you need to be very careful in this particular patient of doing that without knowing what his adherence patterns and profiles are. Okay, so perhaps we can go to what the alternative regimens are in the next question.
I just wanted to give Jess a chance to answer. I saw that she raised her hand for a moment. I'm not sure, Jess, if you wanted to say something in response to that.
No, sorry, that was a mistake.
Okay, cool.
I think, yeah.
Okay, I mean, is everyone happy with that? Is everyone happy with that rationale? I mean, when we're talking about adherence and alternative regimens, we can talk a little bit more in depth about the pill burden issues and the drug interactions. But that concept of risk and room to play. If you had the same patient who was otherwise completely well, okay, who hadn't presented with an opportunistic infection, that risk is slightly lower of progression, and you may have some room to move. But here is a sick patient, and I think that is the issue that we need to deal with.
John, I just wanted to ask you, I mean, obviously we've got this example here, but like what kind of a CD4 threshold would you have in your mind? I know this is anecdotal, but you know, in terms of where would that threshold lie in your mind as to, okay, so we don't have a lot of time in this patient, but maybe in this patient we've got a bit of time. Do you think maybe a CD4 of 50 would be reasonable?
Look, I think any sick patient with a CD4 less than 200 I'm worried about, but specifically a CD4 under 100. Look, we know that CD4s less than 50 are a special high risk, but in a sick patient with a CD4 less than 100 is certainly on my radar as someone that we don't have much room to move.
Okay.
If the patient is completely well, okay, you know, a CD4 above 50 to 100, you must remember these are profoundly immunosuppressed patients, but you know, we have a lot of patients walking around that on a daily basis. As long as you can initiate, you know, I'd say a CD4 above 100, closer to 200, I would happily initiate that first line if that was seen as appropriate. But you know, I think that debate is almost moot when we come to some of the later discussions, because you know, in that patient, you know, the concept of changing to TLD versus putting them on a second line regimen, you know, we'll get to discuss that and look at some of those issues. But yeah, I think, you know, that's the ballpark I'd be looking at. But certainly I'd look at, are they sick or they're not sick? Because I think that does make a difference in terms of what the evidence has shown.
Yeah, and in this particular patient, if we didn't have much of an HIV virological suppression history, what would you do in this case? Would you opt to change him onto a different regimen, or would you restart him on his initial regimen?
I would change this regimen. I wouldn't be happy with that risk profile in him, and it's very likely that he's got resistance to his first line, and I don't think there's much reason to continue in his first line when the risk is such. So I would change.
Cool. All right, shall we move on then? Here's the next question.
May I interject? So sorry, just to bash through, Dr. John. What I want to know is that it has been emphasized as a rule of thumb that number one, never change a single drug in a failing regimen. I want you to integrate your response to that. Never change a single drug in a failing regimen. But number two, it is emphasized that every patient who had defaulted or for whatever reason, during restarting, you need to reinitiate on the old regimen because you do not know where the patient was. So I want you to respond, especially to this one that says that never change a single drug in a failing regimen, because I hear that you are emphasizing that profile the patient and what, but on the guidelines, the guidelines are emphasizing that rule of thumb, never change a single drug in a failing regimen. Thank you.
Absolutely, that as a rule of thumb is reasonable. I will get to some of the evidence later in terms of the new clinical trials that are out that do discuss this, and I'll show you some of the background issues around where that discussion will come from. So that's absolutely fine. And you know, in terms of the general rule of thumb, in that if a patient presents, you want to put them back on their original regimen, that as a rule of thumb is good. But in this specific indication, okay, you are essentially weighing up the risk of pre-existing resistance, okay, to try and assess that, to decide whether this patient has time to mess around with a regimen that may or may not work. And if you get it wrong, the consequences here are potentially dire. So you actually don't have the time to start a regimen and play around with it. So in general, yes, I would agree with that. But in this specific case, in a sick patient who's HIV positive with an opportunistic infection and a CD4 count of 3, what I'm saying here is you don't have the luxury of time to be able to restart it and then mess around with it. So I think that's the I think this is a caveat to that second issue, and then we'll talk about your first issue in a bit more detail now.
Cool. Just before we dive into this one, I see there's a hand raised. I don't know if you want to just unmute yourself and ask your question. Okay, maybe it was a mistake. Shall we press on?
Yep. So if you decided to start on a new regimen, can you start this patient on TLD? So this is that single drug switch issue that we're talking about. And based on this, there's pretty much an even split. Okay, of the 19 responses, we basically, I think probably we had half of them, saying yes, half of them saying no, and one person out of those probably saying, I'm not sure. So is there a representative from each group who can maybe have a quick response? So perhaps someone who said no. Okay, no one wants to be brave. Okay. So I think this is where some of the newer evidence is coming out in terms of what are the potential options in someone who is failing first-line therapy. Okay, I'm using this as a proxy marker of first-line failure, although we haven't confirmed it in the case I'm taking based on, so what I'm saying here is that I'm going to take it as if it's first-line failure and use this case as what is your approach to a patient who's failing first line and the options that are available, and then we can tailor this specific decision to this particular patient. Okay, so first line failure, current guidelines is if you've been on TEE, you've got one of two options. You can go to AZT, 3TC and dolutegravir, AZT, 3TC and lopinavir, ritonavir, or potentially you can go to tenofovir, 3TC and lopinavir, ritonavir. Okay, so those are your options. Can you use TLD? Okay, and the evidence for that I'll show you now. So perhaps I'm just going to share the screen again. I just want to get okay, so this is one of the newest studies that's come out this year, looking at basically people who are failing first-line therapy and putting them on either AZT, 3TC and dolutegravir or AZT, 3TC and darunavir, ritonavir. Okay, and basically what this study showed, and I'll go through to some of the results here, that at week 48, and this is important, that those who were on the dolutegravir regimen, regardless of what the resistance profile was, and regardless of whether they were on the AZT or the tenofovir group, they had a 90.2% suppression rate versus 91.7% in the darunavir group. Okay, so basically, one of the conclusions here is that regardless of what NRTI resistance you have, okay, whether you've got tenofovir resistance and you use tenofovir, if you've got AZT resistance and use AZT, as long as it's together with another good drug, in this case dolutegravir or darunavir, either of those was good in terms of suppression rates of up to 90% in these groups. There was a small concern of resistance to dolutegravir in 4 patients. Okay, and this is very similar to another clinical study that was called the EARNEST trial in patients who were failing therapy, and regardless of the resistance pattern to NRTIs, the use of tenofovir, the use of any 2 NRTIs, not tenofovir, plus lopinavir, ritonavir, basically showed good suppression against, in that particular case, it was against an integrase inhibitor plus a PI. So what it shows that if you are changing from first line to second line, regardless of what your NRTI resistance profile is, okay, your options are, as long as you have dolutegravir, okay, lopinavir, ritonavir, or darunavir, ritonavir, regardless of your NRTI profile, you can use those essentially as single drug switches. So this is what the evidence shows at the moment. Okay, the benefit of the PIs over the integrase inhibitors at this stage, there's very little emergence of resistance in the PI groups, and there is a concern about the evaluation or the emergence of resistance in the dolutegravir group. Okay, so although the national guidelines suggest a 2-drug switch, okay, some of the evidence coming out now suggests a single drug switch, as long as you're switching to one of the trialed regimens, should be a reasonable option. And I'm just going to see if I can get a. Okay, very little difference in terms of whether darunavir and dolutegravir was different, regardless of whether they were in the tenofovir group or the AZT group, regardless of the CD4 count. Often we find in some of the other clinical studies that the PIs potentially look better at lower CD4 counts, but generally they perform very well.
So John, this is kind of in opposition to the previous logic that said the initial dolutegravir regimens needed to be given with one proven active NRTI.
So look, this is not clinical guideline. So your question to me was, can we give TLD? Okay, so at this point, what you need to weigh up, and this is something that we occasionally do, okay, but it is, if you just, let's go back to this particular patient now. You've got a patient who's on TB treatment, okay, who's got a CD4 count of 3. You're concerned about the use of TEE, so you're looking at your particular options. So if you look at each of the options that are available, you've got AZT, 3TC dolutegravir, or TLD, if you're going to use the dolutegravir regimen, AZT, 3TC, and lopinavir, ritonavir, or tenofovir, 3TC, and lopinavir, ritonavir. Those are the 2 main regimens you've got available to you. Unfortunately, we don't have evidence for the atazanavir regimen, but it's something that you would need to think about, but we struggle giving atazanavir with rifampicin. So we can't do that, and we can't give darunavir, ritonavir with rifampicin either. So that's another big issue. So if you look at what options are available, you've got a once-a-day option. Okay, the only once-a-day option you've got there is TLD. Otherwise, all your other options are either double-dose ritonavir, lopinavir, so you, instead of 2BD, 4BD, together with the AZT and 3TC, or even tenofovir, lamivudine, lopinavir, ritonavir double dose, or AZT, 3TC, dolutegravir. So all your options other than TLD here are twice-a-day options. So if you've got a patient who's adherent, who doesn't mind the side effect, GIT side effects of lopinavir, ritonavir, and the pill burden associated with this, okay, then you can potentially look at that. Here you've got a problem of an HB of 6.8. So theoretically, the AZT, 3TC, and dolutegravir option is also difficult. So I mean, the TLD in this case, sorry, is not once a day, it is twice a day, but it's just the DTG, which is twice a day. So in terms of pill burden, you can get away with 3 tablets with the TLD, and you've got major contraindications to the others, and your last option is a lopinavir, ritonavir double dose. So, you know, it's a difficult one, and you're weighing that pill burden issue up against the risk of an ineffective regimen in a sick patient. So in some cases, and often what I would do here is go with TLD plus D in this particular patient, okay, and then watch that patient closely and see how they go. And that's really based on this evidence that is emerging, but there is, you know, from a public health point of view, you can argue it's reasonable, and on a patient point of view, you can say, look, this is the option that we've got available, this is the risk, and I'm going to monitor the patient and see how they go. So that would be the options when you look at this patient and how to deal with it. The option of tenofovir, lamivudine, and double-dosed, you know, Alluvia, you can try it, but it often is intolerable with these patients, and they often don't do as well. And I can show you another clinical trial called the Dawning trial, which looks at, well, let me just I'll give you a quick look at that. Okay, the Dawning trial is, let me just share the screen. So the Dawning trial, let's get back to the top in a sec. Looked at dolutegravir versus lopinavir with dual NRTI inhibitor therapy in adults with HIV-1 infection where first line had failed. So basically what they did here is they did resistance testing, and they chose either dolutegravir or lopinavir ritonavir together with one other active NRTI. Okay, so here they had proven NRTI susceptibility, and basically they showed when administered with the two NRTIs, dolutegravir was superior to ritonavir boosted lopinavir at 48 weeks. And a lot of this was driven by side effect profile. And we know that lopinavir ritonavir has an incredibly difficult side effect profile to deal with. So, and let's see if I can get that one graph. So, as I said, a proportion achieving viral suppression. So you can see 84% versus 70% overall. Where it came close together was with a very high viral load. Okay, but otherwise, dolutegravir really outperformed all the other ones. So this is where you've got a confirmed second agent with either AZT or tenofovir in the majority of cases. But it really shows that dolutegravir is a very good drug switch, and based on these two clinical trials, one of the suggestions is really that that we need to be looking specifically when you've got an emergency switch, that TLD in the shorter term can certainly work for your patient. So if you decided to start on a new regimen, can you start this patient? So although it's not in the guidelines, in specific cases, I would consider the use of TLD, yes, knowing that it has some concerns around long-term resistance, but it looks like as long as it's robust, then we can, we should be able to use it going forward, specifically in these types of cases. So I see Dr. Ntutang has raised his hand for quite a long time.
Yes, Doctor, good day, everyone. I have a problem with the lecture for now, because what you are saying is not on the guidelines. And then most of the people that are invited to come and join are following the guidelines in government. So whatever you do in research does not have to affect us until the guidelines are changed in government. Whether the TLD is working more than Jarunavir or what, we need Relpivirin maybe instead of dolutegravir is another topic. So I thought today you are going to teach us how to do the guidelines, the government guidelines, because now we have South African HIV Clinicians Society guidelines. We have private practitioners guidelines with the medical aids. Then we have government. So maybe we are attending a wrong thing or what? Because I thought you were going to tell us how to behave in a government situation. Thank you very much.
Okay, now thank you for that input. So I think, as I was trying to stress earlier, that this is a very specific clinical scenario where we're trying to weigh up the risks and benefits in this specific patient of how to do this, and really was to try and give you an idea as to why in this particular patient with this particular risk profile, because getting it wrong in this particular patient is one of those things where the patient is going to suffer and where the gap in the guidelines. So this is really what I'm trying to elucidate to you, is that the gap in the guideline here is something that, if you follow the guideline, it is to the detriment of the patient. So this is that one clinical scenario where there is a concern. So it was really to highlight the thinking behind it, what the evidence for that is. And I appreciate that the majority of this is really around what the options are in these particular patients based on guidelines. And I think the cases that follow, I think, will elucidate that to some degree. So I think if you give it a bit of
time. As a follow-up, colleague. So as a follow-up, if you say there are links, there are gaps in the guidelines, there's a political statement, and then it will never take us anywhere. So probably those who are above there can discuss it, that this is the wrong way, because we are guided by the guidelines and we are in government. So it's going to create a problem if you come up with something. And that I understand that the research that we've done, all those things that have been done are very, very convincing that probably you don't need to go even to third line. You can work with TLD. But in government scenario, what should you do? Because now, if you say, you talk about the Nadia study, you talk about all those studies. Those ones are for the research purpose. But we are government. We are in government, so we have to follow what is there. So what should you do? I can understand if it's a private patient, I can do whatever I can do. But what about those in government? Thank you very much.
Could I maybe just jump in here and say that, obviously guidelines exist to try and guide clinical decision making on the ground, but throughout the history of antiretrovirals and the management of HIV, there are tons of different scenarios where it's hard to apply the guidelines. Clinical cases they don't read textbooks, and that is why specialists exist, and that is why HIV hotlines exist. And this is, like John's been saying, this is a clinical situation that we're coming across quite often, where the guidelines actually they don't give complete clarity to what to do, and there's always a time between issues of guidelines being released when new evidence comes out, and we need to be interpreting and applying that evidence even before new guidelines come out. But maybe just moving on, just to kind of summarize, John, I have found this really interesting because we've sort of been taught that, based on that Dawning study that you presented, that using dolutegravir in second line, it needs to be given with a proven active NRTI such as AZT. And so when a patient is very anemic, such as this case, you kind of get a bit stuck. So it's really, it's really helpful to know that there is evidence to support that dolutegravir behaves similarly to PIs when given in a second line regimen with NRTIs that are resistant, because it is really, so many of these patients are anemic, and so it really helps.
Okay, and I mean, the context of, as I said, guidelines is, look, yes, they are there for a reason, and we do need to stick them as much as possible. And yes, and I take the point, but I think, if we can use them for what they need to be used for, and where we see gaps, we do need to be able to fill them, because ultimately it's the patients who suffer. Anyway. Thank you for that, and I thank you for raising that concern. But I think we can move on.
Cool.
Was it, did you have another response, another concern? Your hand was raised, or is it's down now?
Yeah, I think we should try and move on. We've got a bit to go through still. I think there's probably a bit of
If you decided to change him to second line, what would you use? Well, I mean, I think there's an even split as to all the different options. And again, there's no, if you go through these, the concern here with the low HP is all of the AZT related options are very difficult. Okay. We know that lopinavir ritonavir works with any of the other agents. So you could use abacavir, lamivudine, lopinavir ritonavir, tenofovir, lamivudine, lopinavir ritonavir. But again, the big issue there is around tolerance with the double dosing. So I think you individualize it to your patient. You see what you can use, and then you go with it from there. Okay, let's move on. How would you apply the findings? I think we've already discussed this. And in terms of the drug interactions that are important here, certainly remember dolutegravir has an interaction with rifampicin. You've got your double dosing of your lopinavir ritonavir, and then you need to look at your toxicity. So the renal function was reasonable. So tenofovir is something you could use, and from an AZT point of view, obviously an HP of 6.8 is something that makes it very difficult to use that. So, but I think we've covered all these issues.
Cool, awesome. That was a meaty case. Shall we just move straight on to this one, John?
Yep. So Mr. AS comes into your casualty in severe respiratory distress. He is diagnosed with PJP based on suggestive chest X-ray, LDH, and a beta-glucan, and the LAM is negative. Tells you she started ARVs in 2020, but she doesn't know the name of the medication, but it was a pill once a day, and she stopped taking the medication, stopped taking it for 6 months. Results are, so it's a fairly short duration on ARVs with a CD4 of 68, clat negative, sputum gene expert negative with a decent hemoglobin. Okay. When would you reinitiate your ARV regimen? Immediately. So certainly I would support an earlier ARV regimen, so either immediately or within 2 weeks, obviously depending on whether she's taking orally, how hypoxic she is, what your clinical state is, but certainly you would aim for within the first 2 weeks and as soon as possible. We know the evidence here is supportive of that, and I certainly wouldn't wait 8 weeks because the mortality in that subgroup is much worse. So yes, I would agree with that. And what regimen would you reinitiate her on? Okay, so TLD, tenofovir, emtricitabine, and efavirenz, or a second-line regimen. So here you've got a little bit more room to move. Okay, you essentially have a patient who is short-term on a single drug regimen. So one of the concerns is how long does it take to develop the resistance? So yes, if she was on a first-line regimen, you might have efavirenz resistance, you might have lamivudine resistance, but tenofovir resistance in a short-term patient is far less likely. Okay, and the question here is this a drug switch or virological failure? And I think that's really the question you need to ask yourself and say, look, are we going for a straight drug switch, or is this something that we need to be concerned about in terms of the safety and efficacy of this regimen? And I think in line with what we've discussed already, if you are happy that she was compliant on her regimen, it was a short term, she had been on it for a shorter period of time, you could consider a straight drug switch as what you would use as your option. If her adherence was terrible, you do still have the concern about resistance, but the resistance to tenofovir in this case is far less likely to have developed. So TLD, is that a reasonable option? Yes, that's a reasonable option, not knowing what her first line option was. You just know it was a single drug regimen. TFE, is that a reasonable option? It is reasonable. Her CD4 wasn't too bad. Okay, you do still have the risk issue associated with this patient. Okay, if you are going to start an ineffective regimen in this, there are some concerns. But again, the likelihood of an ineffective regimen with this is less important because her time off therapy and her time on therapy were both very short. Okay, and would you use a second line regimen here? Okay, you see there's no one who's voted for it. You may have some people, if you feel that this patient really was poorly adherent or there were other concerns about resistance or failure, you would consider it. But I think either of those options, TLD or TLV, would be reasonable in this particular patient, looking at the timing on ARVs. Now remember, normal drug switch of a single drug within the first 3 months is considered absolutely fine in terms of the guidelines. Okay, but I think you need to look at the patient individually and decide what the likelihood is of resistance, and then you can make that educated decision, not knowing what your first line option was. Okay, so I think, we know that the TLD, we don't even do resistance testing in the guidelines now within the first 2 years of therapy, unless there are other concerns associated with it. So certainly if she was on TLD first line, it would be safe to continue TLD as first line. If she was on TFE first line, it would be reasonable based in this case on her exposure to go with TLD anyway.
It's interesting reflecting back on on the previous ARV area where you just needed to ask, if a patient was taking one pill at night and then you knew exactly what they were on. Things are a lot harder now.
No, absolutely. I mean, the concept of an FDC, if you prescribe an FDC, that could be one of 100 drugs. So people need to be educated a little bit about at least acronyms of appropriate acronyms of what they're on, so you have better information to be able to go on for these patients.
Yeah. Cool. All right. Let's go on to the next one.
So 41-year-old Mr. SM comes into your clinic with an elevated viral load of more than 1,000 for the past 3 months on 2 occasions. Been on TFE for the past 5 years and was virally suppressed up until his viral load slowly started to climb, and he takes his medication well every day. Okay, so here's a patient who's adherent, and you've got multiple viral loads above 1,000. His HB is normal, his creatinine is normal, his CD4 count of 256, a viral load of 2,794, whose hepatitis B surface antigen negative. So, I mean, this is your classic first-line virological failure, and you've got all the options on the table available to you. Okay? Would you change this patient to second line? I'm very happy to see that you've got 100% of people saying yes. All too often at the clinic, we have just keep trying to suppress the viral load because the patient wants to stay on the same therapy because it's easy. Okay, so that unfortunately drives resistance. So I'm really glad to see everyone decided to change the patient. Okay. What regimen would you change them to? Okay, AZT3TC dolutegravir, AZT3TC lopinavir ritonavir. Okay, so obviously with each of these, there's a risk and a benefit. Okay, they are both within the guidelines and they are both appropriate. The drive is really to go more towards AZT3TC dolutegravir, even though it is a twice-a-day drug. The side effect profile is much better, and the tolerance and adherence on that is far better. So I'm glad to see the majority of people went for AZT3TC and dolutegravir. It is probably the more appropriate option in this particular case, and I would support that. I see Dr. Dutang has his hand up again.
Yes. Good day again. You see the problem now. You are saying we give AZT3TC and DTG. Nah? And then now you are talking about the Nadia study, which says TLD can work. You see where the confusion comes now. If you say the second regimen, you can use tenofovir again. That's why Mr. Molefe asked a question before. What do we do? Do you use tenofovir, lamivudine, and dolutegravir, or we have to change to AZT? Because those are two things. According to research, you can also use tenofovir, but in the guidelines they say AZT. That's where the confusion comes.
Okay.
Thank you very much.
So thank you for that. So I think, let me clarify this. So this particular case, I think, has no contraindication to the use of AZT, and following the guidelines, those are the options we've been given. So AZT3TC and dolutegravir is fine, where in the first case, there was a contraindication to the use of AZT. So in that particular case, based on the evidence, which is not yet in the guidelines, we were happy to go with it because that really is the only option. And being the only option that was available, that reassures us that that is a reasonable option. So until the guidelines change, I think we stick with this. But in the option where AZT is not available, we are comforted by the fact that we have tenofovir to use it, and we can do that fairly confidently going forward. When the guidelines catch up to the evidence, then this may change. So I would say stick with this in the meantime, unless there is a contraindication to AZT where we can feel comfortable with the use of tenofovir in that case. So I think that would be my approach for the moment. And where you need to individualize it, you can, knowing what the limitations are and knowing what the restrictions in the guidelines are. So I think that will hopefully clarify that issue.
And that was sort of the teaching with interpreting the earnest trial as well, was that it wasn't just a complete license to just throw any NRTI at a PI. It was, try and construct the best regimen you can. And when you do have, an option to use AZT, then definitely use it. But it was more just reassuring you when you didn't have those options available that would still work.
So I mean, just thanks for that. So the two issues here is what the HB is and what your hepatitis status is. And knowing those two issues, you'll have obviously a preference for tenofovir when someone's Hep B antigen positive, surface antigen positive, or the hemoglobin is very low. In those two cases is when the tenofovir is then preferential. Otherwise, especially when the creatinine is abnormal and there's no other contraindication to AZT, then we can go with AZT in those cases. So I think that as a broad principle now, I think that's something we can work on.
Yeah, that's really helpful. That's cool. Sorry, there's just someone that's not muted. Let's just see who that is. Cool. All right. Shall we move on to the next question? It's actually just a point there. I think, John, you've probably spoken through this already, just there at the bottom. Potential benefits of an integrase inhibitor versus a PI backbone in the second line. I think you've kind of gone through that already, yeah.
Yeah, I think they're both very good drugs. The benefit of the integrase is the once a day versus lopinavir ritonavir twice a day. Remember, we do have other PIs that are also once a day with a more tolerable profile, like atazanavir ritonavir, okay, which are available where lopinavir ritonavir is intolerance. But obviously the drug interaction issue, they both have problems there. We haven't spoken about the issue around lipid profiles and things like that, but certainly there are differential lipid profile problems. So the metabolic effects of them are also slightly different, but they're both very good classes of drugs for second line therapy.
Cool. I think we've got two short cases that each kind of illustrate a point. So shall we just go through them quickly and then we'll be through them.
Okay, so 28-year-old NS comes to you saying she wants to fall pregnant and needs a checkup. Newly diagnosed HIV positive with a CD4 of 400 and otherwise normal bloods. Her GXP, I presume, is negative and she's asymptomatic. Okay, so obviously she needs ARVs as soon as possible. Okay. Okay, so how do people feel about this? So this is really about the teratogenicity effects and issues associated with the fabrins. And there have been some concerns, but with time, these are getting less and less and less. And there's very much a drive towards going with TLD in these particular patients. And, certainly after the first trimester in this patient, there would be no issue with initiating TLD. The use of TFE is reasonable, but obviously with the national guideline push and the fact that dolutegravir drops the viral load quicker, it has so many other benefits over efavirenz. I think in this particular case, I would prefer TLD as an option, both to, for specifically from a long-term issue and the speed of viral load suppression. Dylan, are there any other issues you want to highlight from this particular case?
Yeah, I mean, I just wanted to kind of ask the question, is it, has dolutegravir's name been cleared in court, if you can put it that way? Do we have license to initiate it in childbearing women and women very early on in pregnancy? Do you feel like we've reached that point?
I think the evidence is building and it's much, much closer to being at that point. Let's put it that way. I think the final, certainly there's a lot of advocacy towards that. Okay, but in terms of the final thing I saw there in the chat was, would it be reasonable to put on TFE and then change it to TLD later? Absolutely, there's no issue with that. But I think more and more the push is towards to go with TLD. But it's not finally cleared? No. I think that's the short answer. So, but I think the fear around it is certainly certainly reducing, and people's confidence in TLD as the evidence builds is getting more and more in favor of TLD for multiple reasons.
Cool. Awesome. All right, so this is the last case for today.
38-year-old GM comes to clinic with a positive sputum, Dean expert result, wishing to initiate TB treatment and found to be newly diagnosed HIV positive. Okay, so obviously the issue here is really on the drug interaction issue. Tenofovir, fine in both lamivudine or emtricitabine, fine. The question is the dolutegravir would have to be given twice a day and the efavirenz once a day. Okay. Again, both options are reasonable, but the benefit here of efavirenz is that it's a once-a-day dosing. There's lots of data associated with it, and we know that it's safe in TB treatment unless there's underlying liver issues which become expressed, on treatment as a form of a drug-induced liver injury. But certainly from an ease of taking the therapy, a fairly low side effect profile, TFE in this case is a reasonable option. But in terms of the TLD efficacy, again, it is good, but the only downside to this is that it's a twice-a-day dosing. So in terms of efficacy, one versus the other, there's no real issue when it comes to TB treatment and the effect on TB treatment. They should both do just as well. And really, this comes down to a pill burden versus toxicity issue. So there's no wrong choice here. And they're both options that are available to you. And I think you can use either of them. So
I'm quite surprised to hear you say that, because I must be honest, my understanding was always that, giving dolutegravir together with TB treatment with the drug interactions there could potentially make dolutegravir vulnerable to resistance, in the same way that we've seen PI resistance with TB treatment.
So look, I think the issue there is around adherence and also what happens at the clinics. So we know that a lot of PI resistance comes out because people don't dose adjust. And also you've got major stock issues with single drug dolutegravir. So the patients then only take the TLD and they don't take the dolutegravir. So as I said, if you trust your patient and they're happy to take it twice a day and you can do that, that's not unreasonable if you're wanting to keep them on the same drug. But from a programmatic and simplification point of view, with a single drug option, and you're not concerned about, and if there are concerns about dolutegravir access, I would certainly stick with a TFE as a simpler option in this particular patient. But if you're looking at purely efficacy issues, they would be equal, and I'm not too worried about the resistance in dolutegravir developing unless you're looking at how our program functions in South Africa, where a lot of the drug resistance comes in because we haven't given the appropriate second drug or double dose the, like in the lopinavir ritonavir group, or they give atazanavir with rifampicin and then we blow the atazanavir. So I think it's about educating, it's about stock control, and it's about ease of therapy. And on that basis, I would go with TFE in these patients.
Okay, cool. Awesome. I see that we've reached 6 o'clock. I'm sure there's lots of questions that people could ask, but I think we need to wrap it up. John, just looking at the sort of 5 cases that we've gone through as a whole, any kind of take-home messages that you'd like to reiterate, just for those listening?
Okay, I think the first, I think the guideline, going back to this issue, is for the majority of patients, and the guidelines are very well written and they cover a lot of issues. There are always going to be people who, specifically that sick patient, where you're not sure of what to do. And you need to individualize sometimes what you're doing, knowing what the options are and how safe the options are to be able to deal with that. So I think that one category is that very sick patient who presents to your hospitals, and that hospital-based HIV medicine in the critical HIV patient is something that does concern me. And hanging on to patients and continuing with failing regimens, whether you know it or not, comes at a risk to your patient. And I think in that specific subgroup, there's an art to the management of those patients. It's how do you diagnose opportunistic infections? How do you get them back onto the right therapy? And banging on with regimens that you're not sure are going to work, or you know the patient isn't tolerant of, because that's the other big issue is the patient who's on second line who comes in failing, and we keep putting them on the same Illuvia, knowing that they'll never take it because of side effects. That's when you say, look, let's try something else. And that maybe is a discussion for another time. But in that very sick group, I really would encourage people to ask questions, to refer those patients, discuss them in detail, so we can come up with regimens that we know are going to work for that patient, rather than the broader population as a whole who's not so sick. So, yeah, and then otherwise, these cases are complicated, and there is a lot of new stuff coming out. So when you have questions, please feel free to discuss them, to refer them, because they are complex, and it's okay to not understand or not have a clear view of what's going on as you see them. So please ask questions.
Cool, awesome. Thank you so much, John, once again for your time. I think I'm going to get hold of those studies that you shared, and also the earnest trial, and pop them on the group just for people to look through if you're interested. But if you have any questions that we didn't get a chance to ask, please feel free to drop me a message. I'll put my email address in the chat, and then feel free to drop me an email, and then I can forward it on to John. Thank you so much for your time, John, and have a lovely evening further, everyone.